And even as people are still taking their seats, I want to repeat something that Rosemary said during that last session, which I thought was very interesting. The whole session was fascinating. But Rosemary said volume is the driver of bad care, or is a driver of bad care. And it's really important to remember that, I think, that this sort of gerbil wheel, as Elliot Fisher says, that physicians are so often on a gerbil wheel and nurses are so often on a gerbil wheel, doing, that it's easy to forget to do the things that really matter, and it's easy to make mistakes. So I just wanted to kind of reiterate that. One of the countries I failed to mention is Denmark, and one of the books that we failed to mention is just out by Peter Gotche from Denmark, who is here. Thank you for coming, Peter. And it has a very provocative title, Deadly Medicine and Organized Crime. And I leave it to you to go find the book, and you will find out what it's about. It's a very interesting book. So a couple of, three announcements. One, we have a few dinner tickets left for this evening. There should be someone out up in the area, up in the atrium there who can get you a dinner ticket. Videotaping with Lena is continuing, I think, tomorrow. Lena, is that true? She's probably still taping. And Brian Klepper, I want to introduce. I've known Brian for several years. He is a healthcare analyst, an entrepreneur, and the principal and chief development officer for We Care, which is an on-site primary care clinic model and medical management firm that places clinics close by workplaces. And Brian is going to moderate this very interesting panel of a series of examples of things that really work. So thank you all.
Good afternoon. We have a very distinguished panel, and let me go through the bios on each of them. Nadia Chambers has worked in a range of National Health Service organizations and is currently Dementia Champion and Strategy Lead for Health Education England and Dementia Action Alliance. Matt Hanley is Medical Director for Quality for Group Health Cooperative, one of the nation's largest consumer-governed healthcare systems. Dennis McCullough is an in-the-trenches family physician and geriatrician, an advocate of slow medicine, and a longtime faculty member in the Department of Community and Family Medicine at the Geisel School of Medicine at Dartmouth and the Dartmouth Centers for Health and Aging. David Hirsch is the director of the Cambridge Integrated Clerkship at Cambridge Health Alliance, a longitudinal integrated clerkship for third-year students at Harvard Medical School. And Rushika Fernandopoul, my friend, is a practicing physician and co-founder and CEO of Iora Health. His work was featured in Atul Gawande's New Yorker article, The Hot Spotters. With that, we'll give each speaker about 7 minutes to describe what they're doing, and then the games will begin.
Thank you very much. I feel as though I ought to start by saying welcome to the Magic Kingdom, because this feels like the Disney session after the last one, because this is about the art of the possible. And now that I've done my cultural piece, I'm going to slip back into being really English. So I'm going to talk to you a little bit about some work that I was involved in. Let me put it into context. Having invented the mother of all healthcare systems, we now have the mother of all budget gaps, which is causing massive, massive strain on our finances. I suspect you're aware of that. And there have been a number of initiatives to try to overcome that. Some of them have been driven centrally, through the government, through the Department of Health, and a lot of them have been played out locally. The piece of work that I was involved in did have a central driver, but actually it turned into something far bigger and better than anything that could ever come from central government. The right prescription was a call to action to tackle the inappropriate prescribing of antipsychotic meds to people with dementia. Now, in terms of the scale of the problem, and again, I'm locating this in England, which I'm mindful it can fit into probably any one of your states, but without the apocalyptic weather. This was really looking at the fate of around about 180,000 people who we thought have dementia. And I say we thought because this is from epidemiological studies and survey work, and the figure was extrapolated out across the country. but who had dementia and were on antipsychotics. We also knew that there were low diagnosis rates, running at around 40% at the time. And that meant that actually what we really knew, as opposed to what we thought we knew, was that there were probably about 75,000 people who had dementia who were being prescribed antipsychotics, because the only way to know about them is that they have a diagnosis and that they're on a dementia register in a primary care facility with a general practitioner. We also knew that there were some real issues around harm and antipsychotic prescribing for people with dementia. 3 out of 10 of them suffer a stroke, 1 in 10 of them will die, and those are either directly attributable or significantly attributable to being prescribed antipsychotic medication. Let's put to one side the fact that most of these medications are actually prescribed off license in England. That is to say, they are not designed to be given for behavioural and psychological disorders in dementia, and that's what they're prescribed for, and that's not what they're there for. They're for people with psychosis. So we have a problem. If it was happening to children instead of frail older people, it would be an outrage. But because it's happening to frail older people, many of whom are tucked away in care homes, in nursing homes, and no one really gets to see them. So if they're a little bit gaga, or even not, dead silent, sitting in a corner, not eating, not drinking, but not kicking off, then that's probably okay. But it isn't. So we decided that what we needed to do was to take quite a unique approach. And what we did was we borrowed mercilessly from our colleagues around the world, not least from Professor Marshall Gantz at the Harvard Kennedy School, and took their model of community organising and began to bend it and reshape it so that we could try to make it fit what is, by no stretch of the imagination, a real hierarchy within the NHS. We looked at things like engagement and mobilisation. We looked at distributed leadership. And we decided that what we needed to have was a central action that could be taken by those people who are instrumental in getting antipsychotics into someone with dementia in the first place. And that single agreed action would be to undertake a clinical review. The clinical review is absolutely fundamental because, as anyone who is practicing in healthcare will know, it gives you a moment to stop and reflect and discuss and build the relationship that you might have neglected, and maybe to start again. Because most decisions are reversible. Many decisions are right at the time. They're not right 6 weeks later. They're certainly not right 6 months later. And for people on antipsychotics, they can't be right 2 years later if they've never been reviewed. So the key players that were involved in this across the country were the prescribers, the primary care physicians, the old age psychiatrists in secondary care, the people who are writing out the scripts for antipsychotics for whatever reason at the time, and some of those very good ones and some of them not so good. The dispensers, the pharmacists, who were really our secret weapon in the call to action, the people that were there to support the prescribers, who were there to perhaps look at, from a safety aspect, is this the right thing to do? Because they see the script and then they dispense it. The supporters in healthcare, the nurses, the therapists, everybody else who is surrounding those people with dementia and who may be in a good place to question whether or not prescribing antipsychotics is the right thing to do. And the commissioners of healthcare, the people who put in place services, approaches, access to things that are a viable and sensible and, in many cases, an evidence-based alternative to the prescribing of antipsychotics in BPSD. What we found was, by having a national launch, having a national profile, engaging a national leadership team, and by national I mean people who are involved at the very highest level in clinical leadership through the Royal College of General Practitioners, in governmental leadership through the Department of Health, through having leaders in nursing, through having leaders in pharmacy, through the Royal Pharmaceutical Society, that we had a very high national profile logistics team that didn't just lead from the front, they did from the front. So there were operational task force who met by teleconference every week and drove this work forward over the period of time for which it lasted, which incidentally was from June 2011 through to the end of March 2012. So we're not talking a very long period of time. This work was aimed to do something at scale and at pace. We also felt that we ought to play the system that we know so well. So having political cover was a canny move. It's very difficult to buck the system. You can rave and you can rant about it and you can say you want to change it, but sometimes a Trojan horse approach is the one that gets you the results that you want. And it was a pragmatic one as well, because it just so happened that our Secretary of State was having a passing interest in antipsychotics and dementia and thought it would be good to have a target. Now, that had to be held to one side. You feed the beast and you get on with the real work on this side, which is about working with healthcare providers, healthcare professionals to get these clinical reviews done, to help them be with the patients and their families and carers in that decision-making process, rather than just looking at an arbitrary target, which may well have been picked out of thin air for all I know. We also felt it was really necessary to build relationships, and did that through virtual networks, building resources, capturing data which didn't previously exist, and putting this all through an improvement framework, because that helps people to see the journey that they've taken. It helps them to see where they've started, where they're heading to, and how far along that journey they are. A little bit of a whistle-stop tour, but I've been given a little nudge by my chum here, so I'm going to be quiet now, but happy to take any questions later. Thank you.
Dr. Handley.
Oh, I think I'll just sit. Thanks for the opportunity to share a story. What I'm going to do is talk about what happens out at group health, which is in many ways an island of rationality. Most of the time this morning I'm hearing about these things we're talking about, and we have plenty of challenges, but not nearly so many because of how we've been organized with patients on our board, with an integrated system for financing and healthcare delivery, with 1,000 docs who work together to develop a patient-centered model of care. So shared decision-making, we've heard that word a few times today, and I worry it's a word that everybody nods and thinks they know exactly, they have a very clear meaning, but it might be different than the person sitting next to you. So I thought I'd just explain how we think about it and then tell the story. Shared decision-making is a simple idea that says that there is a process that involves both patients and clinicians that shares accurate, balanced, and complete information about their condition and engages them in figuring out what it means for them, if you will, a diagnostic journey of their values and preferences and unique personal circumstances. Any decision could theoretically be one, but most of them aren't. Most decisions in medicine we don't talk a lot about because they're automated, regular things that just help the wheels go round. There are very important ones that we've talked about today that we need to reflect and make deliberate choices so that we can fulfill Al Mully's favorite quote, which is, "No fateful decisions in the face of avoidable ignorance." The three problems with shared decision-making are, first, risk communication is really hard. Doctors tell their story and they don't test for comprehension. They may have said things that are exactly true. They're in a language that patients don't understand. They go by very quickly, and they don't test for understanding. Whenever I say they, I'm talking about my own errors also here. Second, doctors aren't good at diagnosing patient preferences. Every study that's done on this shows that patient preferences are presumed by doctors, and they're usually not a very big overlap in that Venn diagram between the patient's actual preferences when we talk to the patients and what doctors are pretty sure their preferences are. The third big barrier is that doctors believe patients don't want to participate. And they mostly do that because they strand them with inadequate information and then ask them for a decision. It turns out that as long as we unbundle the medical problem solving, the thing you go to medical school for, to decide what the choices are, from the important part for patients, which is what choice is right for me, patients absolutely want to participate. And the more information they have, the more actively they can participate. In 2009, our story starts with some interesting circumstances where, through some effort through group health, all kinds of serendipity, our state legislature passed a law starting a collaborative to learn about shared decision-making for preference-sensitive surgical conditions. That's a mouthful. That's surgeries where you're mostly dealing with managing symptoms, and reasonable people might choose differently. The simple example would be knee arthritis. A patient can choose to live with the symptoms they have. They might take a medication, they might get an injection in their knee, or they might have a surgery to replace their joint. Any of those things are possible, and the real driver should be how much a patient's symptoms trouble them, how much it impacts their life, and how they feel about the risks of the different interventions and their effectiveness. So what we did was also, it involved these things called video decision aids. We've tossed out the words decision aid a few times. These are videos that are delivered either on DVD or through the web that patients view that help give them accurate, balanced, and complete information, and importantly, make it clear that patients have an active role in taking charge of the decision with their clinician. So they actually show people who have faced that decision talking about it, and they classically show one person who says, that wasn't right for me, I was afraid of surgery, and another person says, thank goodness I chose surgery, it was right for me. In other words, validating the different choices. What we did was decide when the state collaborative started was to say, if we're thinking about being patient-centered, there's more evidence that this delivers value for patients than most anything we do, than many things we do in medicine. On any new drug from the FDA doesn't have as much evidence as shared decision-making does about improving value. So what we said was, this is not going to be a pilot. This is not going to be a research study that randomizes people to get the intervention or not. We said, we're going to do this at scale, and if you're one of our patients and you have one of these procedures for one of these conditions, you should have seen the video. You should have, in epidemiologic terms, exposure to the video. So we set up systems to be able to deliver those reliably to all patients. We then also trained our surgeons. People said it was impossible, but it can be done. All the surgeons went into that training, a half-day training, and they said, I already do shared decision-making. And all of them recognized that that was not true and improved their skills in doing so. What did we find when we did this? Improved patient care experience. Patients are overwhelmingly positive about this experience. Clinicians also said it was time neutral or save them time, which is an important way to blow up one of the big barriers that we've heard today about clinician time. Next, we found that we kind of hit the holy grail. We hit better care experience, better clinical outcomes. We say because only patients that really want the surgery got the surgery, that's a better clinical outcome. And we found in osteoarthritis of the knee and hip about 20 to 25% decreased rates of surgery and lower costs. So that's, I like to call it the holy grail rather than the triple aim. It's a little more hopeful maybe. I'm an optimist. The other thing we've really shown is that this is scalable and doable. We actually measure what % of patients who get these operations haven't had exposure to the video decision aids using administrative data, which is kind of crude, and we're down stable at about 20%, which when we do chart review looks like about right, because the surgeries are sometimes done for other indications. We did this because we had aligned leadership. We did this because we actually organized around the patient, and we recognize that the technical change, which everyone who takes this on focuses on, of distributing the video is not the real story. It's the cultural and adaptive change of having different conversations. And it's completely possible and very rewarding for the groups that take it on.
Great. Dr. McCullough?
Down to the very minute net.
Second.
Or second,
Yeah.
we got our timer down here. Well, I'm delighted to be a part of the panel, which should be a celebration of the wonderful things going on. And I feel privileged also to be asked to represent a lot of programs that are really succeeding in elder care. So the good news is I think we are learning more and more how to do elder care well. The bad news is that for most people in this room, they can't imagine being frail and older. And a part of the challenge for the healthcare system, I think, is identification with and the recognition of one's own aging and what it means. I run a support group for a group of community nurses, and at one point we were having a discussion about what it would take what one thing could transform the healthcare system in terms of its understanding of frail elders. And one of our nurses said, it would be good if every doctor had a very old and frail mother. Because these are transformative times when you sit on the other side of the desk. I was asked to talk about a specific thing, and I'm going to briefly do that and then allude to a few other programs that I'm aware of and work with the leaders of. My own program actually was a very elitist program in that it was a practice which began in 1991 in a continuing care retirement community that occupied probably the wealthiest 15 acres in northern New England. It had a lot of retired physicians, lawyers, professors, and then librarians, business people, and lots of captains of industry who really felt that they could run the place better than any administrators who had come. The general philosophy of the organization that started this, the Kendall Corporation, was that social factors were much, much more important in good elder care than medical care. So they had always had a kind of an arm's length relationship with doctors. They didn't want doctors to mess up good aging. And so I came into that saying, this is going to be kind of a tough place to tread. But I also knew that it was moneyed enough and resourced enough so that unlike most geriatricians, I would have a chance to really have access to resources to design a system. I also was, we put together a committee of residents, the average age at this time being about 82 or 83, to really talk about designing the healthcare system that they wanted, not the one that we were going to provide for them. And the elements that were a little bit complicated to bring into this included the fact that when someone moves to a continuing care retirement community where everything is supposed to be taken care of, that you're supposed to feel that your families don't have to worry anymore, and they won't. And so they won't come and be involved with very many things except to bring the grandchildren to visit, et cetera. But it turned out from the practice of my own practice and that of most people who deal with older folks, that families always show up. As Katie Butler said this morning, it's the cousin from Peoria. There's always somebody who comes in from the periphery. I came to understand the parable of the prodigal son very well. And they were wonderful stories, actually, to the reconciliation of families and the coming together. So what we did is we had a small embedded geriatric team. We tracked our data. Eventually, it got published in Health Affairs a couple of years ago. And the study was relatively simple. We looked at 5 different continuing care retirement communities in similar kinds of collegiate towns and looked at the utilization characteristics of those elders living in the continuing care retirement community and those elders living in the community to compare them, as well as comparing from one community to the other. It turned out that in general, continuing care retirement communities perform a little better in terms of less utilization than a matched group of people who are older and live in the same community. But what we were able to do by practices that I came to call slow medicine, which was really the practice of slowing down decision-making, having shared decision-making not just with an individual elder, but with the people who surrounded them and influenced them, including their family. And sometimes the biggest influences were not family. Those were the features that were most important. The outcome of this is that over a period of time, we've consistently performed and shown that we've been able to reduce hospitalizations by 3/4 compared to the number of hospitalizations of a match group in the other community. We've reduced emergency room visits by 50%. We have 5% of people dying in the hospital. And in general, we've outperformed any Medicare Advantage plan if you look at per member per month figures, including allowing for the fact that we could use our nursing facility as a subacute care center. So we've performed very well. But what I later came to find out is that in meeting with a group of American and Canadian geriatricians from coast to coast, Vancouver, Columbia, Washington, D.C., the coast of Maine, Minneapolis, the characteristics of good elder care that need to be attended to are roughly these. Elder care is relationship-based. You have to engage relationships, not only with the older person, but with their family. You have to earn trust. Trust does not just come because you happen to have a great reputation as a surgeon or someone else, or you're in a prestigious institution. Third, you have got to show up. You've got to show up when it matters. As John Sloan from Vancouver says, any care system for elders which is not 24/7, 365, somebody getting out of bed, you don't have a good elder care system. You're not really going to make an impact. So these characteristics are coming up in a number of different places. And I just feel so proud and pleased to be a part of the elder care world. Is very kind. It's a wonderful place to hang out. Any of you who want to really get involved in changes and work with people whose hearts are deeply, deeply in their work, come join us.
Dr. Hirsch.
Yes, I'm Dave Hirsch, and I thank you so much for including me. I feel it's very refreshing to be in a room full of people who live lives of possibility. And the possibility that I want to speak about is that of medical education. So I was thinking, like, what could be the take-home? What could be an easy take-home? And I hearkened to a paper we had written called Better Learning, Better Doctors, Better Delivery System. Seems like it's the right crowd for this. Although I want to quibble with the title later in this short moment we have together. But Better Learning, Better Doctors, Better Delivery System. So we should think that through. The program we did was essentially the whole transformation of the clinical year of medical school. Better learning, better doctors, better delivery system. How do these relate? So here's how we should go through it. First, we'll do some imagination, right? So could we imagine, actually, medical education that was created out of the sciences of learning, out of the learning sciences, learning theory? Could we imagine medical education that had a system like this, where excellence in the science and excellence in the humanism went together? Could we imagine a medical education program, a clinical medical education program, where the students' duty and commitment and their advocacy and their sense of service, that drove their learning? Those were upheld. Could we imagine a medical education system where it wasn't just student-centered, but it was also patient-centered at the same time? So not just student-centered, not a taking endeavor, but a giving endeavor at once, patient-centered too. Could we imagine a clinical medical education program where the students actually could see the healthcare system not just from the words on the page, not just from the words of their teachers, but they could see the medical system, the delivery system, through the eyes of their patients and through the experiences of their patients because they went along the journey with their patients? And I guess I would say also, could we imagine a medical education, a clinical education program which wasn't just added on or in the way of delivery, but actually served healthcare delivery, made it better or had some contribution to it? Can we imagine that system? So we're kind of like you, and we imagine possibility too, and we tried to create that program. And that thing is called something. It's called longitudinal integrated clerkships. I should thank Beth. She's one of our consultants. And we put this thing together with those values in mind. So it's values-driven medical education with some societal value at the end. Longitudinal integrated clerkships. So ours started in 2004, but the story actually begins in April of 1910. So we'll go back to April of 1910 for a second. Abraham Flexner published what's called the Flexner Report, which essentially was the document that looked at society's needs and medical education's needs and tried to put those together. So the medical delivery system of 1910 is not the medical delivery system of today. I think we could say that April of 1910, the delivery system of then, is not the delivery system of this year. I think we could say that the delivery system of April of 2013 is not the delivery system of today. Fair enough? I mean, it's changing so rapidly. But the news is actually quite interesting because although the delivery system of 1910 is long since gone, the clinical education system of 1910 is exactly what we still do. So we have Flexner's original goal, a kind of a reasonable goal. The delivery system and the education should be aligned. System changed, education did not. So we have a mandate, right? We have to get our clinical education system realigned with the delivery system. And that's also the point of these longitudinal clerkships. It's all very cute, but so how does that work? So imagine instead of block rotations, not math for 4 weeks and no more math, English for 4 weeks and no more English and no more math, biology for 4 weeks and no more biology. We don't do that in school. But we do it in medicine, strangely. We do surgery for 12 weeks and no more surgery. And then medicine for 12 weeks and no more medicine and no more surgery. We can do psychiatry for 4 weeks and then no more psych or medicine or surgery. we don't do this in education, but we do this in medical education. So we thought, no, medical education really ought to be about the patients and their experience of the illness, but also their experience of life. They're people, after all, not diseases, we thought. So we, instead of doing it that block way, the traditional block rotations, we instead gave the students cohorts of patients. They'd have their own patients. Not the patient I saw, but my patient whom I cared for. And they'd have their own personal teachers, right? The teachers are kind of the people who are really the ones overseeing the patients, to be sure. But there's a teacher, there's those patients, and the student is put into that mix in a relevant way. They have meaningful roles. In fact, the patient sees the student as my own personal medical student, right? And the students see the patient as theirs too. Relationships, in fact, do matter so much, I agree. And the students go on that health journey, hopefully also a wellness journey, with their patient, with their teacher, who's a physician, and oh, dare we say, with all the other professionals who are also involved, and the family, and the community. The students are, in fact, caregivers of the fullest notion. So that seems like it's pretty cool as far as alignment with a delivery system that we all would celebrate. So what happens as a consequence of this relationship-based, cohort-driven, longitudinal design where the students follow all these patients for the whole year at once? Not in blocks, but they follow the journeys of these patients with meaningful roles. What happens? They do as well or better on their content tests, and they do as well or better on their clinical tests. And some would say that might be enough. They're much more highly satisfied, for what that's worth. But I think the reason why I might get invited to the room, maybe, is because they do substantially better in humanism. They have a far stronger sense of advocacy. These things sustain over time. And what's most interesting to me, after all, is that they actually are more patient-centered, using valid tools that assess patient-centeredness, and that too sustains over time. So they're different. It looks like maybe they had better learning and better chance of doctoring, and maybe they can actually engage the delivery system in some different way. Better learning, better doctor, better delivery system. And to that I'd say, actually the little rhetorical flourish is completely wrong. Better learning I think we can stick with. Better doctors, I think, is not enough. It's got to be better healthcare professionals overall. If we can do longitudinal design in medicine, we can do longitudinal design in nursing and in many other fields. And in fact, probably the students and the nursing students and the pharmacy students and all sorts of other students could follow the same cohorts together over time. We shouldn't just be cute about interprofessional education. We should actually make it live. So maybe it's not better learning, better doctors, but better learning, better health professionals, better delivery system for sure. We can talk more about that in the question and answer. But maybe there's one more better to do. And I think the answer is, we all in this room, I'm guessing, wouldn't be satisfied only with better learning, better health professionals, better delivery system. We want better society. It's hard for me to imagine, I guess it's hard for you all to imagine too, that we would get to a better society without actually making real change that's deeply meaningful to the participants and stands up for our highest values.
Dr. Dr. Fernandopoul.
Great. So thank you very much for having me here. I am the person standing between you and cocktails, I think, unfortunately. But want to talk about some work we're doing to try and remake primary care. And the cost of care is a huge issue. I think we're fooling ourselves if we think we're going to address the cost of care without actually changing how actual patients get actual care. And I think a lot of what we're trying to do in this realm is what I would call top-down, sitting around waiting for people in Washington to fix the problem, or expecting these huge health systems somehow change things, that it's more than a few committees meeting every now and then. And we decided simply maybe we should start bottom-up and start with where patients first encounter the healthcare system, which is primary care. And get primary care right, and that would help patients actually navigate the whole healthcare system. Because to be honest, as you know better than anyone, the healthcare system is often hostile to our patients' actual interests and needs, as we talked about. And I think it's unrealistic to think they can do it themselves. They need someone who's an advocate who can help them do that, and primary care, a team in primary care is the right place, or a good place to try it. Again, I think we all know that our primary care practices don't work very well, not because of bad people or bad intentions, but because of bad systems. I think most of what we're trying to do is incremental change, take existing practices and tweak them, typically by adding things on, making people do email, run a group, use an EMR on top of what they're already doing. And of course, that doesn't work, right? And we said, why not just start over? If we think the model doesn't work, maybe we need to have the courage to start over and build from the ground up the way it ought to be. And so our model really, you can think of it as three parts. First is get the payment system right. I think what Shannon mentioned is fee-for-service is the wrong way to pay for primary care. It encourages people to churn and see people as one widget off the line. What we should be doing is thinking of, we have a population of people, they are our responsibility. And it's about relationship, about continuous healing relationship, and the way to pay for relationship is not per transaction, because then you get caught up in the billing and the coding. It's just give us a flat amount to take care of these people and let us figure it out, right? That now allows us to completely change how we deliver care. It's about building robust teams around patients, about sitting down for 45 minutes every day in a huddle and talking about our patients, not who are coming in, but who are actually not coming in and are getting into trouble. And what can we do to reach out? It helps us build relationships. We have people we call health coaches. They're folks from the community, speak the language of the people they serve, who can really help patients with all the blocking and tackling it takes to do your healthcare right? Get educated, make a plan, stay accountable. We reach out to people as opposed to just waiting for them to come in. And we build a sort of de facto downstream network where we find a small group of specialists and hospitalists who agree to work in the way that we think is the right way to take care of patients and get people away from the people who don't. The way we work this, and then we realize, by the way, that the IT systems out there, the electronic health records, despite all the hoo-ha and the $19 billion of our tax money about to be spent on it, are really built to help you document, code, and bill higher, and nothing to do with better patient care or helping people navigate the healthcare system. So we've been building our own because no one else seems to want to build one for us. And so we've been doing this for a while. We've had a couple pilot projects. We typically work with self-insured payers. We work with union trusts like United HRE, see Betsy over there. We work with employers like Dartmouth College to serve their members. We work with health plans like the Freelancers Insurance Company in Brooklyn. And we build these practices from scratch. What do we do? So we help people improve their health. We help them manage their diabetes, understand what they do. But a lot of what we do in this context is really help protect people from the healthcare system. And I have hundreds of stories I could really talk about of patients that we've taken care of where I think left to their own devices, bad things would have happened and the cost of care would be higher. I had a patient I met in Atlantic City who was a 55-year-old woman. She was a cocktail waitress. And I asked her about the doctor she's seeing. And she said, well, I see a cardiologist regularly, every 3 months. And I look puzzled and I say, that's funny. You didn't tell me about any heart problems. And she said, well, I don't have any heart problems. So I think, so why do you see a cardiologist? Well, it turned out 30 years earlier, when she was a young woman, she had an upper respiratory infection, and a few weeks later came down with some chest pain. And the chest pain was worse when she laid down, better when she leaned forward. Probably any of you are medical students or even doctors know the diagnosis right away, right? It's pericarditis, a viral infection of the lung. But she goes to her doctor, her primary care doctor, either because, and I never could figure this out, either he's an idiot or a wimp or a crook, decides to send her to a cardiologist. And again, if you can't make this diagnosis as an internist, you ought to hang it up. But goes to the cardiologist. The cardiologist does make the diagnosis, it's pericarditis, gives her the treatment, which is Indocin, right? It's essentially Advil, and says, come back and see me in a couple weeks. Maybe that's okay, because, by the way, this cures it. Comes back in 2 weeks, listens to her, nope, it's all gone. Why don't you come back in 3 months to make sure it doesn't come back? So for 30 years, this poor lady, every 3 months, takes 2 buses, takes a day off from work, goes see a cardiologist, spends 2 hours in the office, listens to her heart, nope, you don't have it, does an EKG, bills for it, once a year does an echocardiogram just to make sure there's no fluid there. And this goes on for 30 years. So I say, there is no reason for you to keep doing this. You can stand down. And so is this? We had another patient came in who asked for her lab test to go see her hematologist. Same question, like, why are you seeing a hematologist? You don't seem to have any blood problems. Well, I did, doctor. 3 years earlier, it's a young woman, had been drunk too much, was throwing up very violently, and had some blood in her vomit. And so went to the ER, and she was anemic. So again, you don't even go to medical school to realize, why is she anemic? She's throwing up blood. So again, this ER doctor, because of the idiot, crook, or wimp, decides to call a hematology consult for anemia, right? So the hematologist comes and says, recommend a GI consult, she's throwing up blood, gets scoped, gets fixed, but then the hematologist says, follow up in my office. Same story. Once a month for 3 years, she goes to this hematologist, he draws her blood, nope, you're not anemic anymore, I'll see you in a month, right? And talk to this guy, she's my bread and butter. Those are the words people use, right? Another doc I talked to called a patient my little ATM. right? And this stuff happens, unfortunately, out in the front lines all the time. So I told her, by the way, if you don't see blood pouring out of your mouth, you're not anemic. You could stop going out there. So again, I think, we need to not fool ourselves. I think we've set up a system in medicine where people are unfortunately at the whim of folks who are using them to generate income. I think there's a professionalism attitude here, there's a payment attitude. Our attempt to try and fix this is to simply build systems where we do the right thing and we try and protect folks from the stuff that's out there. So thank you.
What's delightful about this is that each one of these people has blazed a trail and gone someplace that hasn't been gone to really before, and overcome some very formidable barriers that are built into the system structurally at this point. So I want to exercise my prerogative, and before we begin with questions and comments, I want to ask each of you 2 questions. One was, what's been the most formidable barrier to getting this done? This thing that you have done, to getting it achieved. And the second is, what possibilities did it open up? I mean, I think David addressed that somewhat with his, but how far can this thing that you have done go?
I think the most formidable barrier was ourselves initially, and our perhaps being a little bit shy about being ambitious. And thinking that, how big could it be? Well, actually, it's as big as you wanted it to be, because it was a call to action across the whole of our country. And it was really important that it touched everybody. And when we started to think big and our ambitions got bigger, then we started to get big results. And don't be shy, I think was the message there. What was the second question?
How far can this approach that you've taken?
Okay.
Taken broadly, how far can it go?
I think in terms of the approach that we took was very much a real methodological approach, a call to action. So it used community organising, it used engagement, it used mobilisation. And it works when you have a real intolerable situation that you need to change. So it's not something that you're a bit uncomfortable about, it's something that is an absolute, a complete and utter scandal and has to be sorted, period. Little Americanism there. And the other thing for me is that it will go, it's almost self-perpetuating, and it sounds too good to be true, and I did say this was a bit Disney, but there's a point at which you start to see the success of what you're doing with the people that you're working with the patients, with their carers, with families, and you realise that you can go a bit further and a bit further and a bit further. The only thing that I wouldn't say it held us back, but that we had to completely reinvent was how to capture the data, how to actually measure what we were being, what we knew we were achieving.
That's great.
For me, I like the idea of self-efficacy being something that we need to help our patients with, and it turns out we need it ourselves. I would say I've been thinking this all day, is we have met the enemy and it is us. That the major barriers we have are the institutional thinking that we have wherever our own little microculture is. And what we've done in our most successful efforts has been be patient-centered in our redesign of how to think and not get trapped in the model of pilotitis. So it is so easy to say, because we all know incremental change can be good and sustainable, you can incrementally change people to death. And everybody in the front line in our organization complains more about 17 little tiny changes that are coming every week than they do about a big idea where they think and reorganize their care very differently. It's aspirational, it's inspirational, and it engages people's hearts and souls. It starts with why rather than a tell, and it gets people's spirits moving along in ways that is a flywheel effect.
And how far can it go?
Well, if we get out of our own way, we actually, I think, can solve the major challenges in front of us. One thing that just struck me this morning that we haven't talked about is most of the things we heard about today that are so distressing and challenging, one of the reasons they're possible is because we have such a disorganized model for delivery system. The idea that everybody, that it's still physician autonomy, for half of all of the care delivered in the United States, small mom and pop businesses. And you can't deliver high quality health care from a mom and pop business. It cannot be done. And until we get that elephant in the room out there and say, how are we organizing together so that we have learning systems, we're not going to be able to do it.
I think the biggest obstacle I had to face was my financial minders in my employer, who saw a continuing diminishing revenue stream coming from a group of people where they had very high expectations because they thought it was going to be a very high consuming group. And that went on for many years, even though in the long run they knew it was the right thing to do. In the short run, it was very hard to justify having a practice there when it was, quote, losing so much money. In terms of scaling, I differ a little bit. I think I'm a Schumacher small is beautiful person, really. And I think that for elder care, although you can't scale the program, you can scale and replicate a good process for putting multiple programs into place. So that just as Jeffrey Brenner talked about hotspotters, every place where there's a group of vulnerable adults, and we have loads of nursing homes, and now we have assisted living places and congregate housing for elders, these are all hotspots. And all of us, actually, as we grow older, can overnight become kind of a hotspotter kind of person. You can go from wellness to being a very overtreated person in just an instant. Last night I got a call from friends whose 103-year-old mother was not doing well in terms of relating to them after she'd had a total hip replacement for a hip fracture. And this is a family that had it all together, but when they got to the crunch point, the orthopedic surgeons didn't bother to talk to the geriatrician who had spent 6 years doing home visits for the woman to explain exactly what the risk factors were. So there's a huge issue in terms of prognostication, which I hope that we get to talk about a little bit later.
I like these guys. I was thinking about maybe it is this for me. I think there is a risk that we don't dream big enough. I think there's a risk that some people don't dream enough at all. And I think there's a risk that some people confuse dreams and nightmares. I think they see scary when they should be seeing possibility or opportunity. To say that there's a bit of an orthodoxy in medicine is, I think, to understate it a bit. But it reminds me just to name that because I once gave a talk about the subject, and there was a really wonderful, a very esteemed person in the front row, and she raised her hand, and I was quite excited that she was there and that she was going to make this affirmative comment. It was great, and she commented that she liked the talk, so I was feeling quite good for the moment. And then she says, but you know what, your talk was pretty good, she said. And then she said, in front of this huge crowd, and she says, but I liked your data. She said, but until you have the data, they're going to argue the data. But once you have the data, they're going to argue something else. And I think maybe that's the other way I would, along with the dream metaphor, I think I would suggest that, is that the problem is so large, the data is so obvious of the current situation. And you can even do programs where the data is quite compelling. But I'm not sure that either the size of the problem or the compelling data that there's possible things out there are really the things that lead humans so full of our own angst and our inability to dream that leads us to the next steps.
So taking off from that, I think the real problem is a lack of courage. I think, to be honest, in healthcare, we're sitting and watching a slow motion train wreck. And I think that there's a huge lack of courage among folks who are leading healthcare institutions to be willing to do what needs to be done to fix the problem. It is hard. It is really hard to change. It's hard to do things that are different. Yes, it's risky. But to be honest, I think the biggest risk is we do nothing. You know, I often say we're in a ship and we're heading for the iceberg, so being afraid to turn left or right is almost irrelevant. Because the only thing I know for sure is if we keep going straight, we'll hit the iceberg. You know, I think this is fixable. We've created this stupid system. You know, we can fix it. We have shown in our very little microcosms that we can create a much better vision of what care can be. And you can imagine if you start doing a few of these and people see it and then patients vote with their feet, that sort of gets other people to start doing it. So I think we can fix this if we have the courage to actually do it.
In running the kind of business I run, which are clinics and medical management functions for employers, very similar in concept to what Rushika does, the striking observation is that there is so incredibly much excess and waste. From our point of view, it's probably somewhere on the order of 70% of all the money, by what we can see, has to be unnecessary or inappropriate. And that the healthcare industry, every sector of it, the supply chain, the health IT sector, the care delivery sector, the finance sector, everyone has developed dozens of mechanisms that are designed to extract more money than they're legitimately entitled to, and they're invisible. It's very difficult to see them, and so it becomes our job to sort of put mechanisms into place that disrupt those, while at the same time putting other mechanisms into place that incent appropriateness all the time. And I think that what we've had here are some great examples of things that people have taken on themselves to do. And with that, let's start with the question.
Okay, John Nance here, Orca Institute. First of all, I appreciate everything you guys brought to this. But one thing I want to remind you of, Matt, you were from my area up there in Seattle, Group Health. It was George Halverson, who's just stepped down, in Kaiser Permanente, who said a number of years ago that we do not have a health care system in the United States. We have a great non-system of wonderful people, wonderful parts, et cetera, et cetera. And I think we need to keep that in mind because, yes, we need to blow up what we've got, but what we've got is not only totally dysfunctional, we really need to keep our eye on the ball that we're designing something brand new. And what you were saying, Rushika, about relationships and what was said earlier today in one of the other panels about communications. I want to get to that in terms of medical school because I think it's incredibly important. And I'd like to know if you guys can give me some example here beyond what I know. The University of Illinois, I believe, and the University of Southern Florida have gone to a system, especially Southern Florida, where basically you ask a medical student what he or she is, and he says, I'm a student in health sciences. I'm not a doctor candidate, I'm not a nurse candidate. In other words, they have gone beyond the old traditional model, the one from 1910, and blown that up and put something new in its place. I get a wonderful opportunity every year to talk to the third-year students at Jefferson. We've been doing this about 7 years now. And it aggrieves me every year that I go through this about a couple of hours worth, and the students come up afterwards, not in bulk, but a few of them, but I hear the same thing all the time, and say, why didn't somebody tell me about this in my first year, or my second year, or my third year? And what this is simple communications, relationships, the ability to look at your own errors and say, I'm a human, I'm going to make errors. No one's talked about this. We really do have to change that curriculum. Thank you.
Just a quick response to that. I completely agree. And in our practices, it becomes very clear that the job of a doctor in the system that we ought to have is actually fundamentally different than the job of what we're doing now. It's a lot about relationships and running teams and being a system architect. I think we have to start with the medical schools, but we can't end there. What we see too often is medical students who sort of get it, and then they get put out in third and fourth year rotations, and then they go into residency programs, and they get it squeezed out of them, right? And so I think we need to think about the whole spectrum.
I was just going to say, usually I say the relationship thing has to be approached very carefully because it's squishy science. We call it the R word, the touchy-feely California hot tub psychobabble term.
Vikas?
Yeah, a short comment and then a question. The comment is really that, one of the frames I've started using for what we're doing in healthcare in terms of trying to reform it is an epidemiologic kind of approach. And when I think about it that way, this is where I differ with Don a little bit. It may be that fraud is the tail of the distribution, 1%, 5%, whatever you want to call it. But Rushika, the stories you've told, and our lived experience, I think, indicates that there's that broad section of the tail well beyond, that's maybe 20, 30, 40%, where there's a lot of stuff happening. and it may not be as egregious as once a month, but hell, who says you need it twice a year? How do you know you even need it once a year? So there's a lot of stuff in the system, and as you said, Brian, that's the confidence I have, that there's enormous opportunity. So that's the comment. But here's the question. It's very early, and when you're starting something like you're starting, the conditions that you start with early really matter. What are the safeguards in place for ensuring that you don't cut to the bone, that you're not under-treating, that the patients that come to you knowing that there's their employer or some government entity, or however you want to think about it, that a global payment system doesn't incent startups, large systems, whatever size you have, doesn't incent under-treatment. What are the safeguards, and what do you think about that issue?
Our group does primary care, and we are not, and a very important aspect to our model is that we have stepped outside of fee-for-service reimbursement. So we get paid in two pots of money. The first pot, you have all of our operational costs, the costs of our clinical staff and the drugs and the labs and the office supplies, insurance, utilities. We send our clients a bill at the end of the month, and we say, here is exactly what we paid to run your clinic. Please send us a check for that. There is zero markup. Here's the invoices so you can see that we're telling the truth. Then there's a second bill that is a per employee or per enrollee management fee per month. Right now it's running about $19. And so that covers our enterprise costs, the costs of our marketing and our IT and our administration and my boat. That's the most important part. And in that model, we have no financial incentive to deliver unnecessary care, or equally important, to deny necessary care. At the end of the month, our clients evaluate us on how effectively we have managed care and cost. And so our only financial incentive is to develop mechanisms that assure the appropriateness of care, not only inside the clinic, but downstream throughout the continuum of care. In my opinion, fee-for-service medicine has brought all of medicine into a merchant mentality, where the central assumption is, what more can I do that I can make a margin on? And this model that I have, and risk, provides the opposite of that. There is a financial incentive to deny necessary care. So this other model, this payment model, walks the fine line of of allowing appropriate cost all the time. And in my mind, it's the model that we ought to go to nationally, but that's never going to happen.
You know, I practice in a very unusual place, multi-specialty group practice, salaried physicians, where there aren't incentives to drive utilization any particular direction. One of the interesting things is, and my clinic has about 25,000 patients. I practice part-time there. 75% of our touches with patients are without them coming in. Because if you design a patient-centered care system, a patient needs to get their needs met. And right now, in most systems in the United States, the coin of the realm is an in-person visit, which leads to more overuse just because of the opportunity. If you take out that waste and promote professionalism, and we have a couple of mechanisms to make sure when we are demonstrably in the 10th percentile of different clinical activities, we review and check to make sure we're not having problems with underuse. And we work really hard at avoiding the cost of poor quality. Our model for saving money is to reduce problems like readmission by better transitions. It's by making sure patients drive the decisions rather than clinicians who might have other motives. And you know, I think there's enough large multi-specialty group practices, Health Partners, Kaiser, ourselves and stuff, to prove that really works quite well. And we got to get better at it, but it's certainly a much better platform to start from.
Just one word on that, because I think engaging this idea of uncertainty, which was brought up earlier, that particularly with frail elders, there is uncertainty for them because they don't know when making the wrong decision is going to transform their life radically, very suddenly. And uncertainty for us because there is no really good evidence base for complex older patients. You have to go through this one at a time. So we encourage people to talk to one another, bring families into it, give people the space and time to really reflect on whether or not they want to risk particular things. So creating transparency for each individual who comes through the system is a way of avoiding this rationing. We have no policies. Some people need to be overtreated. That's the way they've always lived. Some people are very spare.
So one last one. I actually agree with everyone. I think we overblow the use of incentives and trying to get the incentives right where we have the perfect incentive and bonus program to prevent overtreatment, also undertreatment. What we believe is we just need to get that out of the way. So we salary our docs, period. We don't get bonuses. We believe in sort of Daniel Pink's book Drive. If I have to pay you a bonus to do the right thing, why am I paying you in the first place? I'm going to fire you, right, if I think you're not doing the right thing. And we do it, right? Because so the right word, I think, is culture. Right? That's how you make sure the right thing happens, is you've got to build the right culture, which means you find the right people, you build the right environment, you promote that, you pay attention. I actually disagree about the big institutions. I actually think the end units need to be small, because then you can pay attention. And everyone knows each other and accountable. Of course, the back end needs to be scaled. Of course, you can't be practicing 21st century without IT systems and analytics and those. But I think that keeping the end unit small, building the right cultures, getting the right people, that's what prevents the wrong thing from happening.
And the trick is to have local autonomy with guardrails, but have enough standardness that you can spread. One of the things, I'm the director of quality for our group. For years, we would have a great innovation in one clinic, no way to move it to another because the way they had organized was so different that you had to start from scratch. And then we put in our version of a patient-centered medical home with 6 models of standard things that happen. Then there's local variation in how. We wanted to tackle the problem with overuse of chronic opioid therapy. Within 9 months, we had 95% of all patients on a care plan that was collaboratively done with them, that's standardized so that problems with refills and reducing unsafe doses was managed across all our 26 clinics because we had enough standardization to be able to then bring a package that would fit locally. It's a balance.
Yes, ma'am.
Good afternoon. My name is Johanna Trimble. I'm a patient advocate from Vancouver, British Columbia in Canada. And I have the pleasure of knowing Dennis McCullough. I set up a public lecture that he gave in Vancouver. I also set up a lecture for a couple of doctors from Halifax, Doctors Mallory and Morehouse, who run something called the Path Clinic. That's pathclinic.ca. Great resources there. They run a clinic for frail elders and their families to help them make medical decisions with real information to do with the patients and families' values, preferences, and context. And that is, do you really want your frail elder who has some mild dementia now to go into the hospital, have surgery for something called an incidentaloma, which may never amount to anything, get delirium, maybe get MRSA, maybe get C. diff, maybe never go home again. Maybe they're now going to have to be discharged to residential care. So it's really getting to know the family and the patient, doing a thorough geriatric assessment, including, all the cognitive faculties, and having a really kind, compassionate, bonded, and frank discussion with the patient and family. An outcome of this was, I belong to the Patient Voices Network in British Columbia. We received a call by email, does anybody want to go to the Surgical Quality Action Network Conference? Now this is something I wouldn't ordinarily go to because my main interest is actually over medication of the elderly, but because I had heard about this problem with surgery for frail elders, I decided to go to the conference as one of the patient representatives. We were asked to actually do an open space conference. That's where you decide what you're going to talk about when you get there. It's not a set up program. The way you do that is every person who is interested pitches for 1 minute a session about what they wanted to talk about. I gathered up all my courage, I went up front and I said, looking at 175 surgical teams, all interested in improving the quality of their work, and I said, I want to do a session on when you should not do surgery. And I ran the session with the facilitator. It was extremely lively. People were very involved and positive. They really needed help on how they can do surgery that helps people, not makes their quality of life much worse. And then at the very end of the conference, what we did is we posted all the ideas from all the sessions that were given. We each got 3 colored dots, and we put them on the proposals. And those 3 that were chosen were going to be the themes for the next year of work for surgical quality. And when should you not do surgery was one of them. So part of that is for me to say how important it is for you to get patients and families with you, helping you push and make these changes that are so important. Thank you.
Thank you.
I am Modena Wilson. I'm the Chief Health and Science Officer at the American Medical Association, and I want to speak a bit to the medical education issues that we've heard about throughout the day. I do so with some trepidation because I believe changes in medical education are necessary but far from sufficient to address the things we've been talking about today. But I do believe there is a lot of promise around change in medical education. It was analyses by the Committee on Medical Education of the AMA that more than 100 years ago led to the Flexnerian system that has been in place for 100 years and almost everyone believes needs to change. David has talked about a very innovative program at Harvard. About a year ago, the American Medical Association put out a request for proposals that asked medical schools what they could do to deliver medical education that is more appropriate for working with patients as partners and for building physicians, training physicians who will be able to deliver care in this rapidly evolving delivery system. 80% of the about 135 allopathic medical schools in the U.S. responded to that request for proposals, which suggests, I believe, that the medical schools are recognizing the problem and we may be reaching a tipping point. So the AMA has now funded 11 schools, giving each of them $1 million to work over the next few years on renovating their curriculum in the ways that all of you are asking for and hoping for. Not only will they be doing that internally, they'll be working together as a consortium, which we hope will allow us, along with schools who are already doing such programs, to really get to scale, which is another challenge that we've talked about a little bit today. That program's called Accelerating Change in Medical Education, or ACE. You would be able to read a lot about it on the AMA website, and I think it'll be very important and interesting to follow over the next few years. And if you are in the range of one of the ACE medical schools, it would be great if you would talk to that medical school and offer your insights and services as those programs unfold.
Thank you. Yes, sir.
Good afternoon. My name is Tom Liu. I'm with the Advisory Board Company in Washington, D.C. I have a question about scaling some of these new models of primary care that we discussed. I was recently at a conference in D.C. where representatives from various health systems were talking about the various changes and approaches they made to adopt some of these new models of primary care. And one system said, we are now very successful at doing so, but it took us 15 years to see a positive return on investment in all the changes we made. And it seems to me that in order to achieve widespread adoption of some of these new models, we need to convince the key stakeholders that it is financially sustainable, especially given how expensive some of these upfront investments might be. So I'm very curious to hear from your experience, what types of approaches have you found to be giving the greatest return in terms of reduced costs or avoided care when operating under risk, and how quickly do you expect we should be able to see kind of positive ROI in terms of the overall business model? Thank you.
We published in Health Affairs a 2-year follow-up of our redesign of a patient-centered medical home showing a significant return within 2 years. So it depends if you're just looking at the clinic versus total system costs, and we're looking at total cost of care, where you can, if you know how to implement well, turn that around pretty quickly. And we're at a place where we were already in the lowest 10th percentile of hospital admissions, and we lowered that further.
And what do you think were the key drivers to those savings?
It's probably our
I can read the
platform.
paper.
The fact that we were already a multi-specialty group practice with physician leadership. We actually invest in training physician leaders. We have able administrators. We run a system well.
Another program would be David Mohn's Bluestone Solutions in Minneapolis, which takes care of 7,000 dual eligible patients using small, mobile, non-office-based teams of physicians, nurse practitioners, and nurses. It's been financially successful to the point where they've recently had a major offer by a health insurer to buy out the program. So the basic thing was cutting out a lot of overhead and really having the team go to people's homes, assisted living, nursing homes, where frail elders were being cared for.
So a couple comments. So one is, I think it's really important that we don't try to save money in healthcare, because to be honest, it's too easy to do. And the way you do it is just deny things to people, and we've seen that movie before, right? And it doesn't end well. So anyone who says we're going to come and save you money in healthcare, I would run the other way. What you should do is, what we say is we're going to do the right thing for our patients, and have a deep faith. If we do the right thing for our patients, there's so much waste going on in the system, healthcare costs will go down. Right now, they may not go down in the first year, because doing the right thing for patients, meaning for some patients, you're going to do more, because the problem is they haven't gotten the right thing before. And so I think you need to have patience. I think it's very unrealistic to think that we're going to do things that have 1-year returns. Since when do we make investments that have 1-year returns? So I think we need to say we're going to do the right thing for people. We understand and have faith that if we do it right, and obviously you have to execute well, we may even see costs go up a little bit in the beginning, because we're going to do the right thing. At Dartmouth, we have a practice. We've diagnosed 6 young women with cancer early because we did the right thing. Their costs went up this year, right? But we did exactly the right thing. In the big picture, are we going to save money? Absolutely. But again, we need to have more than a 1-year window. And I think this is, again, the leadership thing. I think if you're saying, I want a 1-year return, that's not leadership. That's sort of, being a wimp, right? Say, we're going to do the right thing, and we're going to be willing to spend a little time and figure it out.
Thank you.
One thing to add is, I think that there's a fad in healthcare that everybody thinks that there are silver bullets. Medical homes are going to save the world. Disease management is going to save the world. It turns out that there's relatively little data on that. And the real truth is that there are so many areas of major financial risk that are pushed by different groups in healthcare, that in order to be successful in any meaningful way, you have to be attacking all of those different areas simultaneously. So it really does need to be a multi-vector attack.
I have a supplementary question, if you'll excuse me. I'm curious to know, in the absence of any kind of national system or national drivers or things that you have to do because someone up there says so, what levers do you use to scale up what are clearly models that deliver results across systems that work in very different ways that might actually be next door to each other?
Markets.
Yeah, I mean, so what we do is we find, it's markets, right? So what we find is progressive payers, right, who like Betsy Gilbertson and the union, United HRE, like Dartmouth University, who are willing to actually, allow us to do something differently, and then prove the model, and then go to the next one, right? So.
And is there a downside to that?
A downside to?
To using markets as a way to
Yeah, so
make things
it's
happen.
slower. The problem we found in the U.S. is if you try to do it through the political system, it grinds to a complete halt, right? And I think in some ways there are too many people who can say no and too many people who've got a vested interest in the status quo, and we try and do this through the political system and it goes nowhere. I think if we do it through markets, at least here in the U.S., I think we have a shot at doing it.
At the same time, I hopefully learned that for-profit companies that come in with silver bullets, like disease management, take out $1 billion of extra dollars in their profit, have been shown when science is applied not to make a difference. Yeah. So unfortunately, or I should say not to save money, small difference in quality for a large cost. So we have to have the rigor to say that let's test rigorously, and the market doesn't necessarily have that rigor, unfortunately. So that's one of the big challenges, I think.
Absolutely.
Yes, hi. My name is Randy Oster, and I'm out speaking at a grassroots movement trying to empower patients so that they can become their best healthcare advocates. And the way that I do that is first I explain to them the Affordable Care Act, because that is a disruptive function right now for them. And then as I explain what the rules are, I also then explain how to navigate the system. My question is, with the Affordable Care Act, it is an opportunity for a better world as possible, but here's why. Because it is changing their deductions. As I speak to them and they start to look at what their deductibles are, it is no longer free. So someone who's going for 30 years to the same doctor, if she has a bronze plan, she could have a $10,000 a year deductible. If they have a silver plan, it's a $6,000 a year deductible. And so my question is, how do we leverage this? What can we do now that they're going to have more skin in the game out of their own pocket? Is that an opportunity for us to actually help provide education and then create a lot of these changes, because they are going to financially have to change what they're doing?
My biggest concern is, the data that exists on high deductible plans show they erode quality and increase cost. Mm-hmm. So what we put in place is a system with this skin in the game model. What we do when we create insurance packages is the value-based insurance design, where you get your statin or your blood pressure medicine and diabetes medicines for free. And that's the next step that we'll have to get to if we can get past the political logjam, because I don't think anyone thinks this amount of skin in the game is adaptive, especially for the people that qualify. It's probably the wrong turn.
Okay.
I worry a lot, and I think the evidence shows that if you put high deductibles on people, particularly low-income folks, Rand Health Insurance experiment, right, 1980s, shows that people are as likely to not do necessary things as things that are necessary. I think we have to be very careful. Patients already have skin in the game, right? It's their own skin. We don't need to give them any more skin, right? What we need to do is give them resources to be able to make the right decisions. And I think we overblow the incentive thing, as I said before.
Can I add one other thing that's just, we talked about it earlier about the power differential. These patients who are coming in are to the health care system or now have insurance are basically less advantaged than most of the people already in it. There was a study published in Health Affairs about patients who lived in the peninsula south of San Francisco, on average with a graduate degree, over $100,000 of income per person in their families, and they said that they were afraid to not do what their doctor recommended because they thought they would withhold useful care from them in the future in retaliation. So if people in the healthcare system, and all of us, it was the scariest article I've ever read, we do not realize how big the power differential is because we look at our intent rather than patients' perceptions of us. And we've got to do more and more to make that differential decrease as much as possible.
Good afternoon. My name is Michael Fine. I'm a family physician and the director of the Rhode Island Department of Health. I want to offer a comment and then a question. The comment actually starts with an amendment to what John Nance said. I think what we have is a wealth extraction system, not a healthcare system. And when you take a step back and build on that, from my perspective, overtreatment sometimes seems as if it's the invisible consequence of the absent healthcare system that we need. If you take Dennis's numbers, and you take numbers from the Southeast Alaska Native Health Corporation, and you take numbers from WellMed, and you take numbers from North Carolina, we all know that reducing hospitalization by 50 to 70% is achievable tomorrow. And we all know that reducing unnecessary emergency department utilization by 40 to 50% is achievable tomorrow. And so in a certain way, Rashika, what we probably do lack is political will. But if we had that will and built a primary care system that took care of all Americans tomorrow, what would happen to overtreatment?
I just want to share my favorite quote. The future's already here, it's just not evenly distributed, as we've seen from this work.
Hi, it's Brenda Sorovich from Dartmouth and the White River Junction VA. So first I want to say that it is so energizing to be in a room full of smart and thoughtful people who are bringing a variety of perspectives and opinions but have the same objective. And I'm finding it, as I said, energizing. But I think there's also a risk here, which is that what we really want to do is, beyond inspiring each other, is we want to take this outside the walls of this room. And I think that there's, I think there's a little bit of a risk in that we could get sloppy in the way we talk about it and frame it. And what I'm thinking right now is this issue of incentives, which I disagree with that they're not important. I think they're very important. But I think they don't operate as directly as we are talking about them. So I don't think doctors and healthcare professionals, and I think Vikas said this earlier, are trying to buy a boat. And so they're doing an extra cath. I think that, to probably murder a metaphor, it's really more like Pavlov. And you do a few caths and your health system thrives and everything goes more smoothly and your life is better and your patients do well because they were going to do well anyway. So, and I think it's not just financial incentives. I think there are other incentives built in, and the one that I think about a lot is this whole clinical performance measurement thing, which has no top end. It's did you do at least one hemoglobin A1C last year? It doesn't say, did you do 15 hemoglobin A1Cs last year? And you might think I'm joking, but I'm sure this happens. So, and I feel like all of these incentive systems, if we talk about them as if doctors are these, or health professionals are these venal creatures, or that we don't think they're trying to do the right care, that's how we fail at making this message something that the bigger healthcare community embraces. I feel like we should start in the place where we assume that everybody has the same objectives that we have and try to talk about it. I think we all think about it that way, but just to make sure that we're talking about it that way so that we can be most engaging to people who may not already be thinking this way. I guess I didn't really have a question, but if anyone wants to comment, go ahead.
Thank you. We're down to 30 seconds. We really need to stop. I apologize. Before we go, I'd like everyone to recognize Vikas and Shannon and the Lown Institute for putting this on. This has been a spectacular day, very refreshing, and I certainly appreciate everything that you've done.
Well, the magic is you all, really, and I mean that sincerely. So it is so much fun getting people together who are so smart and so passionate about something so important. So that's plenty of gratification. So thank you all. A couple of quick announcements. Dinner tonight, the speaker is Iona Heath, and she is marvelous. If you are interested in a ticket, there are a few left. You can get them at the registration desk. There is a cocktail reception for those not going to the dinner or going to the dinner, and that's in the Lighthouse Room, but both events are in the hotel, not in this complex, so you have to walk back across. And I'm sure there are people outside who can direct you. Finally, you can go to the bathroom. It's, but the cocktail reception starts at 5:30. Thank you all.